Good morning, good afternoon, and good evening to everyone, wherever you may be. Welcome to our webinar titled Resilient Primary Healthcare Systems, Lessons from WHO and Countries' Experiences on Pandemic Response and Preparedness. This session is brought to you by the International Institute for Primary Healthcare in collaboration with PATH and Johns Hopkins University, particularly Bloomberg School of Public Health. And my name is Dr. Abinat. I'm the current executive director for the Institute. And at the Institute, we provide technical assistance to different countries, particularly in Africa, in building a strong primary healthcare systems through capacity building, training, program design, and implementation. And this webinar is amongst many initiatives that we undertake to support that mission. And again, saying welcome to our webinar, I will introduce to you our moderator here for today. It's my deepest pleasure to introduce to you Dr. Lindsay Shields, who is an expert in infectious disease surveillance and One Health, as well as a board-certified preventive medicine veterinarian with more than 13 years experience in strengthening infectious disease surveillance, antimicrobial resistance, outbreak response, and building sustainable surveillance systems globally. With experience living and working in more than 20 countries, Dr. Shields provides technical and operational oversight to a portfolio of projects, including activities funded by USAID, US CDC, and Bill and Melinda Gates Foundation, amongst others. She has substantial experience in assessing and strengthening AMR surveillance systems through Sentinel sites and a deep knowledge on emerging infectious diseases and One Health. Dr. Shields has supported outbreak response efforts for outbreaks of Ebola, cholera, typhoid fever, botulism, and COVID-19. Prior to joining PATH, she served as the Director of Training for the Smithsonian Global Health Program, where she led the development of international capacity building and training programs on zoonotic infectious disease surveillance, supported data analysis and interpretation of USAID PREDICT project in Kenya. And she also developed international professional exchanges between Smithsonian Institution and partner organizations in Kenya and in Indonesia for infectious disease surveillance and outbreak response. Dr. Shields also served as an Epidemic Intelligence Service Officer in the CDC's Division of Foodborne, Waterborne, and Environmental Diseases on the Waterborne Disease Prevention Branch, where she also led outbreak response teams for cholera, botulism, Ebola, and typhoid fever in both international and domestic settings. While at CDC, Dr. Shields also supported projects to improve WASH in healthcare facilities and analyzed both outbreak and routine surveillance data to inform public health action. Dr. Shields has also worked for the Food and Agricultural Organization of the United Nations based in Italy and Ethiopia, where she provided direct assistance to member countries for controlling outbreaks of disease in wildlife and livestock, and supported the development of early warning systems for foodborne diseases in East Africa. Dr. Shields completed her DVM at Virginia Maryland College of Veterinary Medicine, where she focused on epidemiology and zoonotic disease transmission. So again, it's my great pleasure and sincere honor to present to you Dr. Lindsay Shields as your moderator for this webinar today. Dr. Lindsay, the floor is yours. Thank you.
Thank you so much, Dr. Abnett, and thank you so much to our panelists who are here today to share their wonderful insights into this important topic on resilient healthcare systems, both from a global perspective and some really great country-specific perspectives as well. I'm really looking forward to hearing from our panelists, and really, it's a pleasure to moderate this panel this morning, my time, afternoon, and evening, depending on where you are. Thanks as well to all of the participants. I see we have over 160 people who have already tuned in, and this was recorded, I believe, for those of you that may need to drop off or come back later. So thank you so much, everyone, and really looking forward to the discussion today. Before we dive into our first presentation, I also just want to flag, please do not hesitate to use the chat to introduce yourself. I see many are already doing so. We are looking forward to hearing and seeing where everyone is calling in from. And I would also encourage you to use the Q&A if you have any specific questions for the panelists as they go. We'll be looking at those questions as they come in, and we will absolutely have some time at the end for a real discussion with our key colleagues. We'll be looking at having presentations from each of our panelists this morning, and I won't waste too much more time before introducing our first panelist. It's my sincere pleasure to introduce Rheda Sefeldin, who's the Technical Officer with the Health System Resilience and Essential Public Health Functions team at WHO. She has years of experience that cuts across health system strengthening, health security, and their interlinkages at global, national, subnational, and health facility levels. Her role at the WHO focuses on supporting countries to operationalize the concept of health system resilience by embedding and institutionalizing public health capacities within health systems in routine and emergency contexts. She's been instrumental in developing various WHO technical resources that help guide countries, partners, and other stakeholders to support this health system resilience, including the implementation of a 5-year project on building health system resilience in Ethiopia. Rheda, we are very excited to hear your presentation this morning to really help us set the stage for this discussion in the global thinking on health system resilience. So without further ado, Rheda, over to you. Rheda, if you are speaking, unfortunately, you're muted.
So thank you very much, Lindsay. I was trying to put up my slide at the same time. Yeah. So thank you so much for the introduction, and it's a pleasure to be part of this webinar today. I'll begin my presentation. So my presentation will look at the context and lessons from a global perspective in relation to building health systems resilience, and also ongoing and past efforts, and some best practices, as well as some perspectives on moving forward. Now, health systems at all levels, including primary care, in all countries are faced with multiple challenges ranging from slow onset and chronic stressors like increasing economic constraints to more acute disease outbreaks. As you can see here, I believe this is true for all countries. Now, at the same time, access to quality health services remains a challenge in countries while the role of primary care is underutilized. In the context of COVID and other emergencies, we have learned that if quality services are not available, accessible, and affordable for all in routine contexts, and if health services and systems including at primary care levels and other levels, are not designed to withstand shocks, it is unrealistic to expect continuity of services in the face of crisis. According to WHO Pulse surveys during the COVID-19 pandemic, primary care services were amongst the most disrupted. We know that lack of services to access to primary care can often lead to excessive pressure and overburdening of hospitals and other service delivery settings as seen during the pandemic. These further highlight the need for more investments in building resilience by equipping primary care settings with the public health capacities required to tackle public health emergencies while maintaining routine health services. For example, where primary care facilities and community-based service providers can detect and report and manage cases, including contact tracing of epidemic potential cases in a timely and other appropriate stakeholders, we think we can agree that small outbreaks are less likely to become large-scale events of international concern. Now, in the midst of all these challenges, there are many important efforts to strengthen health systems in countries, including health security efforts, tackling specific diseases and humanitarian crises. However, there are gaps in alignment and coordination and synergy between the different efforts, often creating parallel systems and fragmenting the health system. While such parallel efforts can produce quick and short-term results, we have learned that it proves ineffective, inefficient, and unsustainable in the long run and in the face of crisis. Considering that increasing financial constraints, decline in domestic and external funding is a reality in many countries, countries need to make the most of the limited resources available by applying integrated approaches that align both universal health coverage and health security priorities. Example, investment in primary care or emergency preparedness should not create a parallel system, but rather strengthen the health system. Now, as part of efforts to support countries to build more resilient health systems, WHO published 7 policy recommendations for the context of COVID-19 and beyond. This includes a recommendation on strengthening primary health care, not only for universal health coverage, but also for health security, and at the same time to invest in public health functions and address gaps in health systems foundations across all the building blocks. It is important to note that these recommendations must be implemented through an integrated approach for them to be effective. Now, part of the global efforts from WHO headquarters includes more conceptual clarity on health systems resilience. As you all may agree, it has been an emerging concept, an emerging field, mostly during the Ebola crisis in West Africa, when it became a concept that is widely acknowledged as a need for health systems. Since then, we have developed a series of technical resources to provide more guidance to countries in this area. In terms of conceptual clarity, for example, when we talk about resilience, it is not limited to the response phase of emergency management alone, although that is usually when everyone seems to be concerned or put in place efforts for resilience. But it cuts across all phases of emergency management. It involves intentional actions that cut across routine and emergency contexts, cutting across prevention, preparedness, response, and recovery phases with continuous learning and improvement. Now, there are various WHO resources showing the interlinkages between primary health care and essential public health functions. We have defined and developed a list of essential public health functions which enable a comprehensive approach to integrate public health capacities in primary care and other service delivery settings, as well as all health system building blocks. Essential public health functions and primary health care are complementary. Primary health care, for example, is key in delivering public health functions, and at the same time, essential public health functions delivery also strengthen primary health care on primary care level service delivery. The components of primary care, health care have been defined as integrated health services with essential public health functions, multi-sectoral policies and actions, and empowering people and communities. The essential public health functions helps to drive multi-sectoral collaboration at all levels, including the primary care level. We all know that public health challenges require public health, a multi-sectoral approach to public health, as well as multi-sectoral responsibility and accountability. Now, this figure shows how primary healthcare and essential public health functions in health systems can work together to build resilience towards universal health coverage, health security, and the SDGs generally. In addition to development of technical guidance in the area of resilience, there are country support examples. Example is a project for implementation of activities to build health systems resilience. This is an illustration of how we have supported countries like Ethiopia and Liberia to identify and support relevant structures, including primary care levels, to better coordinate and collaborate with other public health structures within and outside the health sector, for example, the animal sector through the One Health approach. This type of intentional approach makes the role of primary care, including communities, more prominent in managing public health threats. This is also from the Health Systems Resilience Project. All activities implemented ensured participation of primary care. Example, in simulation exercises, emergency management planning, to ensure that capacity is built at the grassroots. These examples can be adapted, scaled up, and applied in other settings to also build resilience. Now, the series of technical resources on health systems resilience, including country-level examples and scenarios, are available on WHO website and provide support across policy, planning, operational levels, service delivery levels, in monitoring and evaluation, as well as in capacity building on health systems resilience. So moving forward, many lessons have been identified at global and country levels. Example, through intra and after action reviews in countries, including the need to move from national level capacity development to also build capacity at subnational and primary care levels. There is need to balance between response and health service continuity and address the foundational health systems gaps that increase susceptibility to public health emergencies, and to address the fragmentations and by ensuring more integration within the health sector and other sectors that are responsible for public health and other health issues. However, if these lessons are not translated into actions, we cannot expect them to improve resilience, or we cannot expect improvement in resilience. It's also difficult to say that we have really learned the lessons unless they are unless they are implemented, at least, if not in full, that there are efforts in place to implement them as much as possible and progressively. Note that I use the word lessons have been identified, because learning involves a change in behavior, and we cannot really say that we have learned until we have applied the lessons. And I hope that all the lessons that have been identified, that we will put intentional efforts in place to translate them into actions. There are many opportunities to leverage, including political will and existing and upcoming resources. Making the best of the available resources and opportunities to build resilience is essential. We do not need to wait for new resources to build more resilience. I conclude here by showing that by taking action now to build more resilience in health systems with a focus on primary health care, the impact of subsequent shocks, including service disruptions, is likely to be less than previously experienced. Thank you very much for your attention.
Thank you so much, Rita. That was a great overview of some of the key issues that we're facing and the learnings that have really happened over the last few years as a result of the various pandemics and epidemics that we've been facing. I really loved also hearing about the theme of really needing to empower and support countries and other organizations and stakeholders to shift from this response-driven specific approach to looking at how we can best integrate resilience and response into those existing structures of primary healthcare, who really are the front lines for outbreak response and have the capacity to really ensure that we can mitigate the threat of outbreaks as they do occur. So thank you so much. Please do, if you have questions for Rita, pop them in the Q&A now. She'll be monitoring the questions and may be able to answer some live. We will also have time at the end where we will open the floor for more discussion as well. So we won't do any live question and answer for now because we're going to move to our next presenter. And I'm very excited to take what we've started here with Rita's wonderful overview of what some of the global themes are and what we're seeing from a global perspective. And now we're going to really focus down in on a really strong country perspective. And it's my pleasure to introduce Dr. Christian Ngandu, who is the coordinator of the Public Health Emergency Operating Center in the DRC. He is also an associate professor and researcher and a social epidemiologist specializing in immunology and transfusion medicine. So really understanding both the emergency response as well as that medical side. He has on several occasions managed the preparation and response to public health incidents, notably the ongoing Mpox outbreak, as well as Marburg virus disease and Ebola virus disease epidemics. His expertise includes leadership, operational and strategic management skills, research, and importantly, managing public health emergencies. In addition, he's worked to support quality management systems, implementations, projects related to universal health coverage, and social and behavioral change implementation, really bringing together these two pieces of public health emergency response and primary health care. He has over 10 years experience managing portfolios and projects, both nationally and internationally. And we are very excited to hear from you today. Thank you so much for joining in your busy schedule. Dr. Ngandu, over to you.
Thank you for this introduction, and thank you to join us for this webinar, which is very important webinar. I would like to explain my slides in English, but of course it's writing in French, of course. So I'm very excited to provide this presentation so we can share experience from the DRC about how we can get the resilience after the current response that we are implementing in our country in the DRC. As you know, we in the DRC, we are implementing the response against Mpox. So this response since 14th of August has been activated at a global level as a public health emergency for the highest level. So also at the continental level, it has been elevated at the highest level. It's the same also for the country where we activate the mode response and the maximal response for the country at the level of the Public Health Emergency Operator Center, which is a new structure for the response for the management of public health emergency. So this is our small plan that we're gonna follow for our speech. And so can you go on, please? And the first of all, I wanted to explain which structure of the response that we have in the country. So we know that we organized the public health emergency operating centers is less than 1 year in the country, and this public health emergency operating center is coordinating all preparation and response activity and responders to reinforce the coordination, the collaboration between all responders. That is very important, and it has been some lesson learned from the all previous emergency that the country faced, like Ebola virus, 15 period of Ebola virus epidemics, and other emergency that we have, like cholera and measles in the country. And also, I cannot forget the COVID-19, that's which is the pandemic that the global level faced 2 years before. So after that, many countries are experiencing to develop the FIOC, and as the DRC is doing now. So the response against Mpox is organized with the FIOC, with all organizations and direction and program. So we work together in collaboration to see how we can be strengthened in terms of effectiveness of response, and also in terms of resilience after the response. So as you can see with our slides, the FIOC has set up the HMS, which is the incident management system, which which has been updated according to the importance, the nature, and the complexity of the mpox in the country. As you know, the mpox is the more important outbreak in among all countries in the world. So we did also we saw the size, the nature of all responder for this IMS according to the complexity of this response that we are facing in our country. So you can see also that we have developed all pillars according to the nature and the type of this response mpox, which is infectious risk that we have to face in our country. So the next slide, it's also according, can we go on please? So according to the response also, the approach that we are using for against mpox in the country, it's zone approach. That means that we are going on the zone, the health district, to implement and to develop all activity, and 717 approach. Of course, that 717 approach has been just launched in our country, but we hope that it's gonna be the first experience for the country to see how we can improve the detection, the notification, the detection, and the response according to this response of mpox. And also the third approach, it's we have to work based on our surveillance data. So we cannot create a new system. We will use the same system that's existing to reinforce the resilience in our country, because we don't need to use something new when we have a very strong surveillance system in our country that can help us to provide all data and to analyze together as a side of expertise for this response. Also, other things that I have to mention for this response is this multisectoriality that can help us to capture all those alerts earlier, so we can be very effective. So also, so for this system of surveillance that we are working with in our country, it starts by bottom to the top. So as you can see in this slides, from the community to the national level, we share information, we verify notification information, and we see how we can take some decision according to the surveillance data that we're collecting for this response. Slide, please. Sorry, slide. And can go on, please. Again. And what I want to say for the data, the most important data as we can share for today for mpox, we know that the DSC is the first one to notify the number of suspected cases in the world, but we face some issue to get the confirmed case among the top 10. So now the data that we have, we can see that we have the highest level. We're gonna see with the next slide, but for currently what we are doing, we are implementing the vaccination as vaccination response, which is the first initiative for our country. And also nowadays, we are facing some reducing of lethality case rates in our country. which it was it went from 3% to currently at around 1%. So you can see also that the biological detection has been increased in this response, as we're gonna see the data that we are going to show in this our presentation. So this biological detection went from 9% last year, and now we are around 58%. So how we have done to reach this kind of results, so we will see with the next slides. So also I wanted to mention that vaccination response has been implemented for only 6 provinces. For we have 85%, so it's still going on the process. So we didn't start ended this vaccination process. We think that in a few days we're gonna have the target that we mentioned in our strategy. So also as data that we have cumulative data, we have 35,000 of notified cases, and while we confirm only 7,000. So those data has been has been increased during compared to last year, when we have only 14,000 of notified cases and less than 1,000 of confirmed cases from last year. And as I mentioned, so the lethality case, it's 2% nowadays for when we take the cumulative, but for three weeks it went down a bit at 1%. But we think that we have to maintain all effort to support our effort on the field. So we can go on, please, with the next slide. And when we have to see this distribution of all those suspected cases according to the country, we can say that all provinces, 26 provinces of the country has been affected, but has been affected differently. So we have some provinces in the forests, the central of the center of our country, where we have forest. So in those provinces, we have a high notification of cases that can go with the ecology of the virus of mpox. So we can see that Equator, South Kivu, Sotobangi, Chuapa, Chopo, and also East part, which is something like novelty for this year, because in that the first one, South Kivu, has recorded some sexual transmission of mpox, which is something new for our country, and we are working to see the dynamic, the epidemiological dynamic for this, and to find some factors about this in our response. And can we go on, please? So we're gonna see that this dynamic epidemiology can be shared also according to region. So in these slides, we can see that suspected case has affected those provinces in the center of our country. We can see in blue, and also the death also as going proportionally. So we need to make some effort as to stop to reduce the notifications, also to reduce also all lethality for the same for the same region, and making like that. I think that we're gonna have the hope for the country to reduce the impact of the epidemics in our country. The next one, please. And the same, and here we have used data from line lists, and data for line lists shows the same reality that I mentioned for those provinces in forest place, and those forests are affected proportionally according to the two sources. When I say two sources, I can see IDS, I can see line list as well. All data shows the same reality. Next one, please. And when we have to see the trend according to the time, so we see that the peak of our epidemics, we found it this year with more, as I mentioned, 35,000 of suspected cases. But the 2 weeks before, the trends of suspected case and lethality are going slowly down, but we need to work hard to see how we can maintain the same effort and how we can amplify our effort to maintain this curve going down. Next one, please. Next one again. Next one, please. So here we can see that also those we wanted to compare the confirmed case, according to the line list, where we have more data. So we can see that the confirmed case is going down also, and so lethality when we compare line lists compare versus the IDES data. So we know that the line lists are very more accurate compared to ICDR, but we have to work on the data to see how we can have some action for this. So also I wanted to share with the all for this panel that the biological surveillance, the biosurveillance data, as mentioned in our country, that we have the clade 1, which is circulating in our country. And this clade 1A and clade 1B, the clade 1A has been circulated since while this clade 1B started from this sexual transmissions last year in east provinces in our country, and it spread in Kinshasa and western provinces nowadays. So we are working to see how we can reinforce the border surveillance to see how we can stop the sharing of this clade 1B in according among our country. So this is why we are making the effort as to strengthen the border surveillance pillar in our IMS. The next one, please. The next one again. Yes, here we want to explain now about the vaccination. As I can mention that the vaccination is the first time in our country, in the DRC, we have experienced the vaccination response. However, we have done the vaccination for research in our country, but nowadays it's gonna be to save life. So we launched this vaccination since 2 weeks now. So 6 provinces has been implementing this vaccination. So we can see that we reached this coverage of 85% of people that have been vaccinated in these 6 provinces. So I have to mention that the population at risk and that's benefiting this vaccination is those population contacts that we have in these 6 provinces. We have also the frontline staff. We have also those sex workers and men having sex with men, and also those people they are working in some park, animal park. Those are some population at risk, and they are benefiting this vaccine. So we hope that with this vaccine as intervention, we're gonna limit the circulation of virus in our country, and it's gonna contribute with other pillar to stop our country. It's gonna be like some intervention to strengthen our system and even the resilience so far. Can we go on, please?
And Dr.
So
Nugent, just to flag for you, we are coming up on a few minutes after, so if we can work to wrap up, I know we still have 2 more presenters after you, so sorry to interrupt.
Yes, thank you. I'm at the end of the presentation. Can we go on, please? Can we go on? Those are some advice. So which best practice that we have with our response, Mpox response in the DRC? I can mention that the leadership, which is very responsible, the Minister of Health is the first responsible for our response. That is very important to be effective, and the collaboration between all sectors, animal, environment sectors are involved around the FIOC. Also, the partnership with other organizations, we are working and to strengthen it. Also, implication of all provinces in our response that may give a good direction to our response. Also, for vaccination, population, they accepted very well our vaccine. So we can see 85%, and the research and innovation are involved in our vaccine. That is the last. I'm gonna share now the last slide. For the next step, we think that we're gonna think how to implement to reinforce the healthcare management for all participants to minimize all lethality. We're gonna improve the community involvement in our response. That's gonna make everything very effective, like surveillance, communication, and the prevention control infection. We're gonna write the algorithm for laboratory, and we're gonna also reinforce the research. All research about the mpox in the country must be coordinated. So I say thank you at this. Thank you for your patience, and thank you for your question that I'm gonna have.
Thank you so much, Dr. Ngandu. Great presentation. We will be monitoring the chat. Please continue to pop your comments in the chat. Some of them will be answered by text in the Q&A. Some of them we will hold until we get to the discussion period after our next two presenters have a chance to present. So just to keep us moving, it's my pleasure to introduce to you Dr. Mebratu, who is the Senior Advisor to the Minister at the Ministry of Health in Ethiopia. He holds an MHA and a PhD and is leading public health specialist and senior advisor in the Ministry of Health. With more than 20 years of experience, he's made significant contributions in pandemic preparedness, emergency response, and health system strengthening. As Ethiopia's National Task Force Coordinator during the COVID-19 crisis, he played a crucial role in ensuring this country's resilience during that response. Currently, Dr. Mebratu leads the Ethiopia delegation at the WHO, advocating for global health equity in pandemic negotiations, and chairs the Global Health Security Agenda, promoting international health collaboration. We look forward to hearing more of your experiences. Dr. Mebratu, over to you.
Thank you. Thank you so much, Lindsay. And good morning, good afternoon, good day for everyone participating today with us. And I'm also grateful for this opportunity. I cannot say more than what we heard from my distinguished delegates from different perspectives, from WHO, our secretariat, and also DRC. I think from the horse's mouth that they are really fighting devastating emergency right now. So I'm very grateful for those presentations. So my research, my topic will be mainly focused what works, how we can make in the resiliency in the primary healthcare from Ethiopian perspective only. As you know, Ethiopia is like the second populous country in Africa, second to Nigeria. So I had seen in the chat, we have Nigerian friends also, and I'm very grateful. So we have like together maybe almost half of the African population. So that's in perspective how we can make the fastest growing economy, and the GDP, which is expected to be 1.6 trillion in 2050. And with this, how devastating epidemics couldn't hamper the country's progress. That's the whole strategic thinking we have. But we are very much challenged by increasing emergencies, conflicts, war, and the healthcare underfunded for demand of essential medicine, medical countermeasures, and motivating attrition of health workforce. So as we have seen from the COVID, it really shown us how much we are ill prepared for a pandemic like COVID. So any virus which will stand somewhere in the world will devastate the world in few days. And we had seen also from mpox, we had seen also from the fear of Marburg, and thank you for Rwanda team. I think we'll hear that, but they really did a big job that at least to breathe from the fear. So it's always seen, and it's very much frequent now. And there is estimation that we'll have another very much devastating virus or any other pandemic in 2025 years next. So God forbid, like that will be the essential thing to think when we are thinking about the resiliency of our health system. The climate change is exacerbating the pandemic risks, as you know, and the governments must collectively commit. The amount we must fund for health preparedness, pandemic prevention, and epidemic preparedness is about 75 billion expected. So each year we need 15 billion. So that's not available for now to sustain the investment in the world. So we need major global push for this. In Ethiopian experience with COVID, I think we were very much pretty try to respond in collaborative formats. The main highlights I can share with you is the strong PHC that we had at the peacetime. So it was very much helped us to counter the pandemic. PHC system is very much important and very much effective for emergency prevention and the response, including the mpox I think we heard from DRC right now. So integrating approach using community health workers. So our health system is built from the health extension workers, from the community level, from the Kabali level. That's very much important to have the localized healthcare delivery. Digital health tools are very important. We must work together going forward to enhance the digital tools. Very much important thing is also rapid, effective healthcare response across all regions, all decentralized provinces. It's very important as we all know. Working in hand, especially the health workers collaboration is like magnificent. We are building a future with PH system as a robust and as effective as much as we can. The capacity building, for example, we ran 15,000 training digitally in 2 days when COVID arrived. So it's very important, like to mobilize people and to address it as early as possible. So empowering local leaders, like Ethiopia is very much decentralized country, so we are very much dependent on the regional responses and the district level responses. So the local leaders, the local elders are very much important, including it depends in the context, but the religious leaders are very important for us in our response. Data and the resources that we are sharing, even the families are sharing their meals for the neighbors when we are affected. That was a big experience we had. So majorly in the governance of resiliency, what we think as strategically is we must focus on the surveillance systems. So operational with integrated budget. Otherwise, without budget, without robust surveillance, you will not know what's happening where. That's the most important thing. Testing and the data sharing is important for national lab networks, particularly for medical supplies. We have EPSS, it's the National Medical Supply Agency. We really mobilize everyone to strengthen our supply chain systems. The most important thing we can say in the surveillance is interministerial coordination, One Health. It is, I think, mentioned by WHO colleague also. It's very much important. We need to strengthen the drills, and it's not fully integrated yet, but we are working towards that plan. We had prepared plan guided by NAPS, which is National Action Plan for Health Security. So it's fully integrated, and we have launching second NAPS in a month's time. Coordination, I think EOC is mentioned already. It's very important as a central hub. Command structure is very important to streamline decisions making process, because in emergencies everyone goes like in a work position. So it's very much important to streamline the coordination. So real-time surveillance data is also very much recognized. And the budget, as I said, on international arena, like there are so many tools, so many structures we are working. The main one is health security strengthening, including IHR 2005, collaborative surveillance 717, that we use the matrix to measure how much on time we respond for the emergency. So epidemic-ready healthcare, which focuses on the primary healthcare. So every primary healthcare, as our plan, if it goes, should be ready for epidemics. And we need capacity for that to be really in top of the epidemics as we go forward. Legal preparedness, innovative approaches, including planning and operational inclusion of the plans in the existing health system plan. So every health facility, every district had its own plan, but it should consider the health emergency preparedness plans and as we go forward. So these are the most important pillars. And vaccination is always important. So we prevent many epidemics by vaccinations. And the topography, thanks for our health workers, the golden health workers we had, they suffered, they paid the price to vaccinate more than 60 million Ethiopians in the COVID. And it's happening every day in other campaigns also. We are not like talking about in country also, we are collaborating as African level with Africa CDC, and also we are going with WHO in the global arena. Also, we are volunteered to chair Global Health Security for 2024. That's a voluntary organization we are taking. So sharing our knowledge, learning from others, ensuring stronger health systems. We are investing in infrastructure and the people, ensuring no one is left behind. No matter where they live, we must create a system that adapts, that grows stronger with each challenge. So the remote community is very much important. There are hard to reach places which we need to focus on when we are building the resiliency that we think important. So, and especially the primary healthcare is the vehicle which will help us to reach those populations and deliver the services as they wanted. And also training thousands of health workforce, as I said, and innovative solutions, telemedicines for connecting doctors with patients in the hard-to-reach areas, community-led health campaigns that build trust and bring people together. Trust is very important for epidemic responses. Any epidemic, any outbreaks, if the community cannot communicate with the health authorities, we will be in danger. So that's very much important to focus. One important thing which is mentioned by the RC is also the leadership. So when we are thinking about the future, we need to engage the higher level leadership, the ministers, the prime minister, the presidents. They must engage in the process. Also, the locally available tools are important. Local production of medical countermeasures and the distribution, like Ethiopian Airlines. It worked well in the pandemic to distribute vaccines and other essential products throughout Africa and throughout the world. Even it traveled to the Brazil, Argentina, so it worked a lot. So there are major challenges. Like I think we need to focus to work together for the future and learn. We must focus on financing. It's very important. Without financing, we cannot go anywhere. So we really need to advocate for financial resources for epidemic response and the resiliencies of primary health care. Dependency on donor funding, which is usually going down, is always disturbing. So we need to focus how we can elevate domestic financing. Inadequate revenue is the major reason in the domestic financing. Private engagement and having dedicated, quickly mobilized emergency funds is important thing we need to focus going forward. Fragmentation of those funds and the donor specification is really difficult to collaborate and coordinate. In Ethiopia, we try to integrate these frameworks. We try to have our local production capacity for vaccine preventable diseases. And also we tried to have essential services stocked for emergencies that we anticipate. And as I said, cross-border, One Health surveillance, and the collaboration is the most important pillar. Equity is always important. We are not like already in equitable field to play. There are some countries who are good advantage in terms of assistance, access to countermeasures, and the intellectual properties, which will help for the countries to manufacture their own capacity. Trust, sharing, and the transparency is very important. health system should be always supported and financed in the peacetime than the emergency. Usually we run for the response with trillions of dollars, but we must invest early to counter such things. And then the last two things I want to say is what we can take from Ethiopia's response. So we have a key role to negotiate the future as we keep the world safer going forward. It's very much seen. It's not about COVID only. We have seen in Mpox. It was a public health emergency of international concern just 2 years back. Then we said we are free. Then we are back. If we are not working in the grassroots, that will continue. The cycle will continue. It continued forever. So we must strengthen global health security agenda. So integrate multi-sectoral governance. It's very important, putting everyone concerned together. It's very difficult, but very important. Sustainable financing, as I said, and the local manufacturing initiative is very important for the countries, for the regions to be self-sustained. Community-centered primary healthcare approach is a cornerstone, as I said, utilizing community health workers and the health workers to be protected and motivated as much as we can is the major pillar we had. Aligning broader development goals for sustainable long-term readiness, not only just running. And investing in the prevention in the primary healthcare is very much cost-effective, very much important, and we are learned from Ethiopian response so far. So when we invest in health, we invest in people. Together, we can build a world where everyone would have the chance to live a healthy and fulfilling life. Thank you so much.
Thank you. Thank you so much, Dr. Mebratu, for that great presentation. I have to say, I really loved the picture that you included of the health worker or vaccine distributor really trying to get through some of really challenging topography that highlights how important it is to really understand the challenges on the ground when we're talking about response efforts and really integrating resiliency into that primary healthcare piece. I think it actually sets us up extremely well for us to just move right into our last presenter, who's going to talk to us really about some of those truly local primary healthcare providers, those community health workers that are really on the ground in the community supporting these response efforts. So it's my pleasure to introduce to you Amy Kakiza, who's the Director of Advocacy and Strategic Partnerships for Living Goods in Uganda. Amy is a seasoned development professional with over 22 years of experience in business development, policy and advocacy, communications, and strategic partnerships. In her current role, she's responsible for the management and supervision of advocacy and government relations, driving policy initiatives that foster meaningful change to advance access to equitable healthcare. Prior to joining Living Goods, Amy has served in several other leadership positions, including as the Senior External Relations Manager at Maurice Stopes in Uganda and the Director of Development for CARE USA. She has a bachelor's degree in diplomacy and world affairs and is certified in nonprofit leadership and strategic management. As part of her passion pieces, she's also a charter member of the Muyenga Sunday Sunset Rotary Club and a board member of the Peace Island Children's Center. Amy is extremely passionate about community-driven development. Amy, we look forward to hearing more about your work with Living Goods. Over to you.
Thank you very much, Dr. Lindsay. Thank you, fellow panelists and attendees. I'll go ahead and put this up to project it. And I'm glad that I'm the last to speak here, and all my colleagues have really spoken very passionately about the resilience of PHC systems. And so you will find that not too much is different here. So hopefully I can be really quick here. Let's see, how do I put this? Sorry, just 1 second. There we go. Yeah, so hopefully I can be quick here, Dr. Lindsay, and really, like you said, zero in on what it is that Living Goods is doing to strengthen and empower community health workers through a very unique approach, and strengthening governments to do the same. Yeah, so I will, since a lot of this was similar, I'll just really talk through the very Ugandan specific approach and the Living Goods community health system strengthening approach. So Living Goods actually is an organization that uses not our own approach, but it's really codified by Living Goods based on WHO principles, the building blocks for community health systems. So we codified it in the acronym of ADESC. And I think our claim to fame is really the digital health strength. Currently, we're supporting Uganda and Kenya in the development and rollout of the electronic community health information system. And we're also very involved in what's going on in Burkina Faso as well on that. So the D, yeah, like I just mentioned, really stands out for the digitization and how we're using digital technologies. It's the smartphone for the frontline worker, and then the digital tablet for the supervisor, which is a diagnostic tool, but it also is collecting very important data in the background. The equipped, as I think even Dr. Mebratu was speaking on, community health workers who really need to be not just trained, but retrained. So when we talk about equipping, again, it's not only the medical supplies and the medical equipment, the commodities and the supplies, but it's also the training. Now, we know in many countries, the community health workers are volunteer-based. However, they do need to be supervised. And so there's a very elaborate performance management framework that is in place. And this enables this cadre to really have, M&E systems, indicators to the best of their ability to support in everything. It goes to identifying sick children, to tracking that, referrals, all done with a very structured supervision mechanism. Then the last, the C, so it's desk with a C and not a K, but it also is supposed to reference a desk that is stable. And without any one of these components, then it will likely fall, collapse. But the C is really all about compensation. And I think, I'll talk a bit about how studies and research have really demonstrated that this workforce really does need to be properly remunerated for the amount of work that they do. And pandemics have clearly showed us of this value. So Living Goods, we have about 17 years experience in community health partnership with governments, because we know we cannot do it alone. The best way for a sustainable system is to work with a government-led and government-empowered system. So we, like I mentioned earlier, we do work in 3 countries currently. Work started here in Uganda, and it's really about children under 5 and women. And we know in pandemics, this is the most vulnerable group of our society. And leveraging digital tools and innovations that even go beyond digital tools, but innovation and digital tools for community-based disease surveillance is very important. And it's through, CBDS that we can really have documentation of a One Health approach. And I think that has been a challenge in many prior pandemics, where if you're not having an integrated system, then the environmentalists and the veterinarians, as Dr. Lindsay would know very well, this information is very siloed. So we need to create a strong framework that integrates this community participation, analyzing data, because data, they say it's the new oil, but we need data, for to make decisions. That's important for us. And that's how we're supporting the governments. So this is, just a laundry list of, when you support a government to strengthen community health systems, you want to know that it is an integrated system. And I think the government of Uganda has very strongly reached out to donor partners, to implementing partners, to say we need to have one system that meets the priorities of government and actually is integrated. And gone are the days, I think, when a community health worker goes into a household and is just assessing malaria, walks out, and another community health worker comes in and is talking about water and sanitation or HIV, and it's just such a missed opportunity to have that really comprehensive approach. And in Uganda, the National Community Health Strategy was launched last year, and it is only mid this year that we've launched revised the community health worker structure to have the community health worker extension who would supervise the foot soldier. In Uganda, we call them the village health teams. And it was really interesting to hear again also the experiences from Ethiopia, which I think was benchmarked on this structure and is just now being implemented. But I'll just highlight, you know, the importance of going into a household and being able to communicate in the communities about the risks of outbreaks, the epidemics, and then of course the pandemic, pandemic overall. And it's this community health worker who reaches that last mile, reaches those vulnerable and marginalized populations. Uganda is also, like many developing countries and rapidly developing countries, you're seeing urbanization at its height and all the threats that has in terms of spread of outbreaks, spread of pandemics, of epidemics that can spiral now into pandemics. And so it's really focusing that community health workers do reach the rural, do reach the very marginalized island communities and, you know, up in the hills, like the image we just saw, but also within urban settings, there is a really struggle of access to quality health services. And so a pandemic can really be a challenge there. So now just speaking of the overview of Uganda's efforts towards a resilient PHC system, and very similar to the previous speaker, political will and commitment at the highest level is really important. During the COVID pandemic, we had our head of state almost every other day on the news, talking to communities, really showcasing how he himself is protecting himself, the ministers, the speakers of parliament, the prime minister. So we really could see this political will and this commitment. And it was during the COVID pandemic that there was a directive for community health workers to be paid. And that has always been such a challenge. But for advocates like us, for this aspect of incentivization, it's like if it was done successfully, then we can learn from that. I've highlighted here that Uganda is one of the founding members of the Global Health Security Agenda. And that agenda, which was launched in 2014, led to an evaluation, and that evaluation really revealed critical gaps in the PHC system here in Uganda. So that really has become kind of a blueprint, a guide for us to see now what do we need to do to plug those gaps. And it is through that the National Action Plan for Health Security was developed. Some of the things that were addressed at the time, and I think we're seeing huge optimism there, is the laboratories. There are two central public health laboratories in Uganda. One, the Uganda Virus Research Institute, that is really well known, and then the new Central Public laboratory. But even in the regional referral hospitals, we're seeing very strengthened and certified laboratories that can deal with epidemics and pandemics. Another issue that has been addressed is how are we skilling the human resource to meet these demands? And so we're seeing more attention on epidemiologists, biostatisticians. Of course, for us, it's data, public health specialists, officers at points of entry for disease surveillance. And then, of course, the infrastructure here on how we're seeing national and subnational task forces and also the isolation units that we're seeing coming out of these gaps that have been identified. So Uganda is implementing an integrated disease surveillance strategy as well. And this has really improved disease surveillance, as we've seen in most of these more recent epidemics. And I think also we're drawing from the experience in COVID-19. And before the country even recorded its first case, there were very stringent laws in place. I mean, the schools were closed for 2 years, and I think to many of the citizens, it was really a stretch. But in hindsight, realizing that, you know, to address something as demanding as COVID-19, it really called for drastic measures. Then some of the other ideas were, you know, how we restricted travel, Uganda being a landlocked country, it really required port checkpoints and really almost draconian rules that were set in place in terms of public gatherings. And some of these responses we also were seen in Ebola. So it was taken from COVID and replicated for the Ebola outbreak. I just also wanted to highlight the foundation of Uganda's resilient PHC systems going back to the HIV pandemic. And I think Uganda was really noted as one of 2 countries, the other one being Thailand, that really reversed the HIV pandemic. And so you saw a lot of agency, a lot of strong political will, and the president really almost coined the ABC approach on abstinence, being faithful, and abstinence, be faithful, and the use of condoms, as it became, you know, kind of everybody was speaking about that. But it does require really a national approach to respond to this. And then another reason, again, not only are we landlocked, do we have, you know, the geographic constraints, but then also the climate issues, being right on the equator and having having such weather challenges. It makes Uganda an ecological hotspot, making it really very vulnerable to disease epidemics and the pressures that climate change brings. A coordinated national strategy is also something that has been noted as an approach. So it's not only multi-stakeholder that requires a response in this, but also multifaceted in the different approaches. And now back to how community health workers really support. And, you know, with that, this dovetails, you know, quite well to show that this hotspot, we've had 7 outbreaks since 2000 of Ebola. And Marburg has been another threat with 3 outbreaks. Not too long ago, it was last year, yellow fever was such a challenge. And then, of course, COVID, and more recently, Mpox, with over 80 cases and 1 death to date. But what are we seeing as the best practices? We're seeing that, health education that the community health worker brings, going door to door. And these are, like, again, the previous panelist highlighted, they're trusted members of their community. And we know in many of our societies, there's a lot of myths and misconceptions during times of outbreaks of pandemics. And so it's only a community health worker who has established that trust who can help, debunk some of those myths and misconceptions from
Amy, I'm sorry to
tradition.
interrupt you, but I will need you to wrap up here in just a minute. We have some great questions that I want to make sure we leave a few minutes at the end to catch on. So just wanted to give you a quick ping.
Absolutely. Okay, thanks for that. So like digital tools are quite a strong enabler, and of course, documentation, research and documentation is really key. Project Birch, I just wanted to mention that real briefly. It is a project that has been funded through the Global Fund, and it's really to support our countries. It's right in across 17 countries currently, to really strengthen the bottlenecks, to identify the bottlenecks and put strong foundations in place to respond and institutionalize and scale community health systems. So in Uganda, Living Goods has been appointed by the ministry, or selected by the Ministry of Health to implement Project Birch. Some of the lessons learned, again, these have been already highlighted. One of the lessons that we took from COVID and we've seen is the emergence of self-care. So it's really citizens taking care, their health care in their own hands, and not really waiting on government, but what can they do to be able to protect themselves and their families. Partnerships, including private sector, are very important. Working closely with Africa CD for the norm settings, and some of the strategies, recommendations, and regulations that we are able to replicate. Key working areas and the way forward. Again, this is really highlighting or amplifying what has already been highlighted. But integrated service delivery, is something that I think is really important, and we're seeing many African countries move towards. And I'll just also end with something to say that a very famous musician said, the only real mistake is the one from which we learn nothing. So given our past experiences with COVID and the recent outbreaks, I think for us to learn something, and not just learn, but act on it, prepares us for resilient PHC systems. Thank you, and over.
Thank you so much, Amy. And again, sorry to have to move us along. I just know we have a lot of great questions in the chat. In fact, what I'd like to do is ask Dr. Mabratu and Amy, there are some questions in the Q&A that are specifically targeted to you that I think you can probably type an answer for. So if you can go ahead and take a look at those questions while we dive into also some live questions, that would be great. The first, I'm going to also try to combine some of the questions in the Q&A so that we can get through at least 2 questions before the end of our time together today. So the first one is for Reda, and maybe Amy, if you have a moment, you can also weigh in. But what do you see, Reda, as the global and country approaches to build in health security and pandemic preparedness into training packages for healthcare workers? So Reda, if I can ping you on that one, that would be great.
Okay. So thank you so much. That's a great question. Building preparedness, building public health emergency management capacities into training packages. That was the question, right?
Yes.
Okay. So the approach that we apply is really to understand what the risks are in a particular setting, and based on those risks, so we having an understanding of the risk profile mapping, that on a continuous basis would be important in informing the areas that need to be targeted. Now, the essential public health functions that I introduced earlier provide a comprehensive approach to developing the public health capacities that are needed by health workers to be able to tackle different public health threats or different public health challenges through a comprehensive and integrated approach. So not just focusing on, say, emergency preparedness, but integrating into that the preventive part, the aspects, the health promotion, the health protection, as well as and the different aspects of emergency management. And the capacity should not only be targeted at health workers at that are already through in-service training. It's also important that the pre-service training curricula are reviewed and so that the competences that health workers require. And when I say health workers, the health includes the public health workforce, not just people that are trained specifically for public health, but everyone, all health workers have a role in public health to be able and it's important that they all have the competences to manage and to address public health challenges that are both ongoing or emerging threats in their settings. So in a nutshell, using the essential public health functions as a way of identifying the competences that are required by health workers is very important. It can provide a comprehensive approach to building health workers' capacities for resilience. And WHO has published a roadmap for national health workforce capacity building, which is based on the essential public health functions. I'll put the link in the chat so that everyone can have a look. Thank you.
Great. Thanks so much. I'm going to actually move to the next question real quick. I know, Amy, you're probably typing away on some of the questions that are specific to you in the chat. The next question is for Dr. Ngandu and Dr. Mabratu. I'm combining a few questions here, but how do we support resilient primary healthcare and outbreak response effort in difficult to reach populations or under conflict settings? I know both of you have probably experienced both of those, so would love to hear your perspective. Maybe I can go to Dr. Ngandu first. I see you're on video.
Thank you, Lindsay, for this question. So we think that working on response and having at the same time the mind to reinforce the public health system is more important. So while we draft our plan, we set up some activity according to reinforce how to strengthen our public health structure and public health system, so we can see how we can build capacity of our workforce. That is very important because this capacity can contribute for the resilience in our country. Also, how we can build our infrastructure for sustainability, because previously we used to build some infrastructure for transitory infrastructure for emergencies. But nowadays we need to have something very sustainable that can help the public health system for a while. So the way we can contribute for resilience when we are responding against emergency. Also, we think that all those very good practices that we learn from emergency, I can take idea about the COVID-19, all those IPCs and WASH that we learned from COVID. Those are some investment that can contribute for the resilience of health system and community. So we need to think about all those main points, to put them to emphasize all those points when we are implementing the response. That is why for the response against mpox, we identify one expert, a group of experts. The role of those experts is to monitor all those actions for resilience. So we hope that at the end of our response, we're gonna have the package of activity intervention that's gonna contribute to the resilience of our health system and our community. I think that it's gonna be like a contribution, a real contribution for the response to the resilience. We cannot
Great.
forget that the resilience is the last step for the public health management for the all lesson that we give to people. Thank you.
Perfect. Thank you. Dr. Mabratu, very, very briefly before I close.
Thank you so much. Let me very short. I answered the question also in chat for details. So how we approach the conflicts, it's very much known that anywhere there is problem in peace, like the first affected among the front line is the health facilities in the health system, because the mothers, childs are the vulnerable groups that who usually be affected by the consequence of any conflict in anywhere in the world. So in Ethiopia, like we're very much devastated with the conflict, with the pandemic, as you know, at the same time. So as the ministry, we tried to really navigate a very difficult system that we try to maintain with supply, especially. That's the most important. In some of the places, even we recruited a cargo to deploy to pass some of the areas to really provide. And as a big country and the conflict is big in different areas, it's very difficult. The response is not enough. It's never be enough, but we are trying to really push that as much as we can. And the health workers are, I think, the most important thing we want to mention. There are really big hearts that they are dying in some of the conflicts, but they are serving the community. That's the important resilient component I want to mention. And also we are trying with third-party implementers in some of the places that the government couldn't reach. So we used different channels from the government supply to NGOs, to civil societies, to reach to the community where the government couldn't establish the local contact. So there are so many mechanisms we tried, and the best thing I can say is avoiding the conflict. Like peace is always better for the health. And then the one point only, then the private engagement, I think is also the same thing. It's something we are developing, because many of our health emergency systems are dependent on the public system. So one of the strategy we are having with private partnership and engaging private partners on manufacturing and PPEs. You remember, like in Ethiopia, we changed the garments to PPE factories in the COVID. So there are so many ways they can support, including the local ones, with supply of water, supply of food, supply of household utensils for someone we quarantined or isolated. So there are so many means that the community could use the private, and we will take note of this also for the future. Thank you so much. Thank you.
Absolutely. Thank you so much. I'm sorry to have to rush. I know we only have 1 minute left. Very briefly, a huge thank you to our presenters who've done a great job for bringing a lot of the really critical pieces here to the forefront. I think we've seen the importance of EOCs, the importance of integrating the data that comes out of EOCs back to the primary healthcare facilities where they're actually frontline response, and how to best leverage existing primary healthcare systems and structures without overburdening the system, and making sure that those primary healthcare efforts, the patients can receive the care that they truly need. I know that there's more to be done and more we could talk about, but we are at time. So betam amaseganalo to our hosts for today. It's been a real pleasure serving as your moderator. Please don't hesitate to reach out to the folks here or anywhere else. I'm not sure, Dr. Abnett, if you have any final closing words before we close our webinar for today.
Nothing more to add from my end, Doctor. I think it was a wonderful session, and I really thank everyone who participated. And I know our audience also enjoyed based on the comments and the messages we have received. So thanks everyone for joining us. Until we meet again, have a great day.
Thank you. Bye, everyone.